steps once they actually follow through with them. Again, communication with both the child and the parent. Be clear, avoid threats, and be mindful of your tone. And I kind of actually want to back up one to the simplify. This is also very helpful with an escalated parent who might see their child in distress and is starting to become very anxious. Give them very short, like, you know, you're scared, stand there. Nice, you know, and so just help like move the room around because they also aren't hearing more than 5 words because they're escalated. So
the other thing that happens is the parent wants to be there and it's more triggering for the patient. So the distraction works by saying to the parents, I need information from you, come help me. And you take them away because we do need information from them and we need them to be, so let me first get you some water because I'm going to need your, you know, background or your ideas or whatever. But that's kind of distracting the parent and removing them, telling them that they're actually helping their child by going to do this instead of standing there and being more agitated about whatever we're doing to keep the patient safe.
absolutely. So okay, so
Aggression.
yeah, so this is basically reducing aggression. Now this, I'm going to kind of explain the whole, do you want to explain autism piece?
Well, this was, we touched on this when I met with you guys a couple months ago for autism, managing autism, but it's really the same. And the things that are going to work to help a developmentally delayed child are also going to help a typical developing child. And so it's like a pyramid, so it's kind of like first, second, third, right, and then medication. So this is now, we've tried our techniques and they're still escalating. So you want to use the first then, so first medicine, then snack, or first, and then reattempt or try a new task, so whatever it might be. And then reinforce any attempts at positive behaviors. You're sitting still. So if that's not working, parents often help with kids, younger kids, right? I mean, I remember being a pediatric resident, if we had to check the ears for any toddler, they don't like it. So you have the parents restrain them, right? And making sure that the parents are holding them in a way that's safe for the parents. If the child starts flailing, mom's not going to get her chin knocked or face hit. So helping guide the parent to hold them in the correct way. And we had another nonverbal 8-year-old child who was acute on chronic, and mom and babysitter were used to restraining him at home, and they were happy to help in the hospital. And he was so agitated, it was really being prolonged, checking in to make sure mom's not getting fatigued, the sitter's not getting fatigued, so monitoring the safety of the parent, not just being like, oh, mom's got this, but making sure, just like we would with staff, how long has it been, are you tired, can we help? And then reinforcing the parent and child for safe behaviors, so just making sure that you're recognizing any small attempt that the child is doing to be cooperative. So if we need restraints with security, it's important to let security know the child's triggers and things that soothe that as we might know. So for example, just yesterday we had a boy who was very disorganized, psychotic, not thinking well, and he was very afraid of security because he had a history of being in juvenile hall and had wrist fractures from being in juvenile hall. Severe injury from a security guard. A juvenile hall guard, right? So in that moment, we still have to follow. Mom was saying, well, I don't want him to have with the sitter. And I said, this is protocol. This is hospital protocol. I understand the situation for your son, and we cannot sway from this. So how can we compromise? What will it look like? And then just letting security know, don't take this personally. He's not well. He's not logical. We can't be logical with him about this. This is a stressor for him. So how can security interact to keep them safe and to keep security safe and keep the child calm? So just really communicating, advocating on behalf of the patients, and helping this. This has to feel bad for security to be painted with a broad brush, But, you know, probably a lot of our patients have had bad interactions in the community with authority, people in yeah. And so just being mindful of what that interaction is gonna look like to be therapeutic and to keep the hospital safe. We have security for a reason. And then acknowledging that restraint devices are uncomfortable if it's a nonverbal kid, if we could have the visuals, and maybe Child Life would help us to still prep them visually. We're gonna put the restraints on. Once you're calm, the restraints come off. And we're rewarding them for being cooperative. And then the next step would be medications, if we're really getting to this point. Or maybe medications would have been done in parallel with this or prior to this, but when hands-on or restraints are necessary.
So now when we do get to the restraints being necessary and when the patient is really a risk to others or themselves and we need to go to room 13 or keep them safe in other ways, then you know, these are different things, different quotes that we have that we use. So it's really taking the safety measures and talking to them about why you're taking these measures. So we're trying to keep you safe. Hitting is not okay. Keep your hands to yourself. So you're telling them what you're expecting from them, because if you say stop, they're still agitated, they still have this emotion and dysregulation. They need to be doing something. They're not really sure what they're doing that is not appropriate at this point. They just feel that anything and everything they do is because they're trying to get out of the situation. They're scared, like the patient that we had yesterday thought that we were going to turn him into an animal, so therefore he's trying to survive and save himself. So telling him he needs to stay in the room is the only thing that he needs to know, that he needs to stay in the room sitting on the chair. That's all we need him to really understand, and that's as much as he's going to be able to understand, and letting him know that we're trying to keep him safe and we're trying to help him, and reassuring him of that, even if the logic is not always there. At least the message is being told that this is our intent. So direct messages about behaviors with clear limits. Cutting yourself is not okay. We have had patients on the floors and even here that have tried and are constantly trying to hurt themselves. So it's saying that that's not okay and that's not tolerable and we're not going to tolerate that. You're being unsafe right now and we're walking you to another room, so letting them know that this is going to happen, that we need to keep them safe, and this is where we're going to take him. It's a room, it's a different room. Not to just walk them out of the room. They don't really know where we're going to take them. Are we arresting them? Are we throwing them out of the hospital? Are we taking them to the environment they're trying to run away from? It's going to escalate the patient a lot more if they don't know that they're just going to another room at the end of the hallway.
The other helpful thing in this category, and that works with parents, and I've used this as a psychiatry resident on a 300-pound chronically schizophrenic man who was taking PCP. So we're talking about a very, very disorganized person, very agitated. And I was there with the police, with the hospital security, and he was so agitated, and I said, you're upset, we want to help you. I can't help you if I feel scared, you're scaring me. And for some reason, it turns out to be very effective. And so to use that with parents, you're mad, I want to help you, you're so mad, I'm scared, I can't help you if I'm scared. And it kind of lets them know, like, oh, I don't actually know exactly how it works, but it tends to work in these situations. And it might not be the last thing you have to say, but it can be helpful just to let them know, like, we are here to help you, but how can I help you if you're this dysregulated?
If you're being unsafe, I can't.
If you're being unsafe, I can't help you. If I feel unsafe, I can't help you. And then that kind of helps.
And it reminds them that you're not there to do something to them, and that you also feel scared like they are feeling, and kind of makes
and that
them be
acknowledging that our intervention, hands-on, is scary. So we're trying not to use hands-on, but we feel scared, right? So.
And that's why we need to do it, to keep
Right.
them safe and keep everybody else safe. So being reflective and validating, I see that you're feeling bad right now. Those are all the things that we talked about before. Feeling that can make you want to end your life, and we're here to keep you safe, so we're not going to allow you to hurt yourself. I see you're angry and you must be scared. All the things that we just want to repeat, and to be able to live with their feelings, be able to validate their feelings. During those moments that we are restraining them or taking them to room 13 saying it's going to be okay, is really not validating, and it's really not true. So you're going to lose the trust completely of the patient. And then medication options. That's something that we encountered yesterday, we encounter all the time. Do you want to take this mouth, or is it going to be an injection of void thread? So we can't threaten. If you don't take this by mouth, then we're going to take you 13 for those patients that know 13. It's something that sometimes we want to use, and sometimes that they use it on us. So what, you're going to take me to 13? So they're trying to get in that power struggle, and you're not supposed to go there. And you're just, right now, I need you to either take it by mouth, or we're going to do an injection, and that's it. And just keeping those two choices and not negotiating them. So if you do it now, or if you do it later, no, like these are the two things that we need to do, and this is what needs to be done now.
So giving them two options, but two options that you're in approval of. Two options that you're okay with either option. Instead of, can I give you medicine? No.
No.
So, medicine
Or
by
will
mouth
you
or
take your
injection?
medicine?
Yeah, will you, you're not, but this is what we do too, like, which ear first, right? It's not, can I check your ears? Which ear am I gonna check first? So two options where you're happy with both outcomes.
I have to say that I think that it's really nice when we're getting in these situations that we kind of determine that who is gonna be that
Sure, the
voice.
leader.
Yeah.
Because I think sometimes what happens, it gets very confusing, everybody's trying to pipe in. Some
Mhm.
people, in their lack of kind of awareness and frustration, are piping in with threats or, the
Or it's
idea
confusing if
of,
security's saying one thing, a nurse is saying another, Bert is saying,
yeah.
then it's like,
Yeah, and I
Yeah.
feel that that's a really big thing,
Should
and I
be united
love,
as a
especially if Bird is here, and they're so more well-versed in the language of using, I feel like when they step up and take that role, I think it is an excellent educational opportunity for people to see that
Observe it.
in action, and I think that the more we see it in action, and of course have wonderful things like this, but at the time when you're able to see it in action, it really makes it stick to your mind.
mm-hmm,
And you're really like,
Exactly.
wow, I remember that, and that went well, and we had one voice, and those are the types of experiences to me. So I know it is kind of, I'm not saying that we shouldn't be a part of it, but I feel like when Bert is here, it's really nice if somebody will be that lead person
And
to kind of
hopefully-
step up and,
if it's a Bert patient,
They're
then Bert
here.
knows
exactly.
and can anticipate that this would be
Like,
needed.
and then we would also know their triggers, the keywords that they're
Mhm.
saying, we would look into the history. I mean, there's patients that come in that have a history of, physical aggression or neglect, or et cetera, that if we know that if we're telling them we're gonna hold you down, that's not the way that you need to say it.
Exactly.
It'd be like, we're gonna keep you safe, and that means that one of us is gonna be at your hand, one of us is gonna be sitting at your feet. one of us is gonna be-
That's exactly it, especially when we start escalating to the point of putting restraints on. I think it's really important for somebody to be that director.
Mm-hmm.
Because otherwise it really does feel, if you've been in restraint situations where it doesn't go well, it really feels like you're kind of taking down a caged animal. I hate to put it that, but it's dehumanizing.
Yeah, it should be a
It-
team approach,
it
there's
should-
one person there's one
Right,
voice.
and direction is
Explaining
being
what's
given.
gonna happen,
You know,
your hands are
Linda,
being
can you go
held.
to her arm,
Yeah.
please?
Yeah.
And then it feels, and in those situations, when it
Calm.
happens, it feels like, okay, we are helping, there's a direction, there's a person in charge. It's not the best thing, but it's not dehumanizing.
Right, yeah.
Well,
And I
and-
can't say that enough for
Yeah,
those
right.
situations. And of course, hopefully, we're gonna avoid that and have gone to medication. And I think that being ready with the medication,
Yeah.
because as soon as we make it safe, hopefully we're medicating so that we're chemically restraining instead
Right.
of physically restraining.
Right.
And so it's just, I think it's one of the worst. I'm
Yeah.
sure it marks and
None of
scars
us wanna
them,
have to
and
give this
as
to them.
providers, it hurts your soul that you're having to get to this point. But, of course, all of those things are the reason we're doing it.
But
And-
that's also like our last ditch effort is the restraint. So what we really want to learn
Yeah,
all of
what
the
are the
simplifying
first
and
things that we
ignoring.
should
Yeah.
do before we get there.
Before you
And
even
also
get
when we get there to remember all the things that did work before and have that relationship with them will help de-escalate the patient at that point. And when we do the inpatient births upstairs, there is a team leader that's immediately identified. So I think maybe that's something that we should definitely put
Yes.
down to the ED and just say, who's gonna be the team lead on this
Just like
patient.
exactly,
And-
just like we would in a med stat or a
Yeah,
code.
Yeah.
exactly, so.
So I think it's essential because everybody's
Yeah.
and it becomes.
And everybody has a different experience
With the patient.
Or lack of
with
understanding.
words, right? Because there are some that have never really had one before.
Yeah.
And so it's hard to know what to do when it's your first time, or you're just having trainings. And I know Linda talked about wanting to do practice.
Yeah,
Or-
practice like mock
Yeah.
role play.
Emergencies.
Yeah,
Yeah.
which would be really helpful, and then we can go down the, who assigns the team leader, how do we identify who's gonna do what, and then medication. When do we call it in and how we call it in, which is helpful. I think, it's hard because an inpatient bird automatically notifies our medication providers, and when we're having somebody escalated here, we're like running around trying to find the medication provider because they don't get notified. So they are probably in session with the patient and won't be notified. So
Of the
we-
emergency
Of
room.
the emergency. So
Yeah.
there's a page that we should have available to us to be
Yeah.
like.
Because certainly, obviously, the attendings will write that Zyprexa order or whatever, but we wanna make sure that we're not being in, something that they shouldn't be.
Like
Yeah.
the patients that have other psych meds
Meds.
and that also have had side effects from other medication or have psychosis or things that we don't wanna
Comorbid
trigger.
medical problems.
It's really, but yeah, there's things that we
And I
can
think that
bring.
when we bring it down here to say that we're gonna have that team leader, it also takes the pressure off, like, if I'm the bedside nurse and things are escalating, sometimes I feel like the bedside nurse continues to try to have that conversation, and whether that is positive or not positive, or therapeutic or not therapeutic, whatever the case may be, it's kind of nice when you say, well, now that it's escalated to this point, the team leader feels that freedom to come in and kind of just,
Take
Do what
over.
needs to be
right,
done.
and the bedside nurse can feel like, oh, well,
Yeah.
it's that person's
And,
I have the
expertise.
support, yeah.
And I'll tell you that in the inpatient birth space, many times that we ask the bedside nurse or the resident, whoever has a relationship with that patient, to stay as the team lead with a backup person lead, that would be the birth clinician, because they're the ones with the relationship, they're the ones that know the patient better than we might know the patient. So that's happened too, but at least we can identify that and have that support for the person that is in that relationship with the patient at the moment.
I have a quick question. My name's Lisa. I'm sorry I'm late to the party. I've been in a meeting since noon. Is this forum also talking about aggression towards staff?
With parents, or you mean patients?
I'm talking about parents coming after staff.
Yeah, so one of the problems with parents, right, is we're not allowed to restrain and medicate them, right? They're not our, right, that's, so.
What?
So any of the de-escalating techniques that are used are for both patient and parent. And so I'm imagining the stuff that escalates parents is usually wait times or perceived
Sure.
misunderstandings about what's happening.
Certainly. I mean, we've all experienced parents who've been very upset with us for various reasons. And it's, and it gets bad sometimes, and there are expletives, and you
Mhm.
have to hit, 55 stat. The difference is because calling a code gray versus calling a
Security.
safety stat.
Uh-huh.
Just how would we, deal with that? And, Teresa, you probably can speak to that.
Well, and there have, all throughout the lecture we've had so far, there have been suggestions on how to deal with parents.
Great.
That sort of have been in
Sprinkled in.
line with how
Okay.
we deal with the
Okay.
patients too.
But it's almost the same thing, I mean, I feel
It's
like,
the same thing,
the
except we
family
don't
members
have
are
the
coming
way to
in
protect
with-
ourselves.
right, dysregulated.
They have their own trauma history,
Yes.
right, and they have
Right.
their own suspicions about medical care. I mean, we get that in psychiatry all the time. This mother yesterday was very suspicious about that the olanzapine was what was causing her
Yes.
psychosis.
I remember that.
And so, in psychiatry, we deal with that all the time because there's such suspicion and concern about psychiatric medications and how they work, and that we, like she said, you're gonna experiment on my son. That particular mother is very dysregulated herself and works as a security guard, so had a lot of judgments about how security should work. Like, he doesn't need a sitter, I can watch him better than they can, I got more training than they have. So with this particular mom, the technique was really just trying to contain her, really not trying to explore too much, just validating the emotion and trying to contain it. And she was saying, I don't want him to take medication, and I said, look, based on my clinical experience, he has bipolar disorder, he's not gonna sleep and he's not gonna be better without medication. You can continue this you're going to a hospital, or you can continue this discussion. We're not making that decision today. But just to be really clear, and she responded really well to these kind of clear limits, and she would try to tell non-truths like, oh, nobody told me he's being hospitalized. Multiple people have told you he's being hospitalized. So just not really engaging
Exactly.
with this whole
Because
thing,
it's not like you're gonna change
he's ready to go
them.
home.
Yeah.
Yes, you want him to go home. Yes, it's exhausting to be here. Yes, it's noisy here. And these are sometimes I tell parents, I'm not making this decision based on your parenting or based on your child. I just met you today. I can't know you. I'm making this decision based on what I know about suicide. And there's too many risk factors about suicide. I don't do it based case by case. These are the rules, and I have to follow the rules. And so that's another way to kind of take yourself out of it. Like, this is hospital policy. The security has to be here. You don't like it, and it's what it is. And so trying to keep it contained. And then just validating, it's really hard to wait, yes, of course, but it's so hard for us to hear this because you know what the hospital's dealing with, and it's like, I'm sorry, but your child's runny nose is fine, but this other child is getting resuscitated, and so for staff to be in this situation where it's like, you know what you're triaging, and to have them make judgments, it's very, very, very frustrating, so trying to not take it personally, and then saying, like what I said, what the example that worked in my psych residency, which I still will use, is you're mad, I want to help, I can't help when I'm scared. Because then you're just acknowledging, like, I feel scared when you charge me, and I can't help you if I'm scared. And it just diffuses it a little bit.
I have to say that whole validating thing, that you cannot do that enough versus giving reasons. Like, I know you're absolutely right. As soon 99% when you say to someone, you're absolutely right.
You're absolutely right.
This situation is really hard, and you have waited a long time.
Yeah.
99.99999% of the time, that's it.
And
But I
it's
think
because
it's
you're dealing with
very-
emotional mind.
I think it's very
versus
difficult
logical mind.
Yeah, or
sometimes.
otherwise you have 6 sheriffs that are showing up because you can't